Thank you so much for everyone coming tonight. I'd like to welcome you to our evening and hopefully information session about pathways to liver transplantation. It's something new we have started in order to facilitate the information exchange and hopefully have some interactive also occasions to ask questions and address questions from your side. So as I said, my name is Markus Selzner. I'm the surgical director of the liver transplant program, and I will just get the session started. We have a number of speakers from our transplant program, from the medical side as well as the surgical sides, and hopefully this will give you great opportunities to ask questions or address the different issues. Zita Galvin will speak first after me. She is the new transplant hepatologist from our program. She will talk about trends of liver disease and treatment options. This will be followed by Les Lilly, who is the medical director of a liver transplant program, and he will address disease donor organ transplantation as one pathway to get a liver transplant. Zubita afterwards from our live donor program will speak about live organ transplantation as a second pathway to liver transplantation. And David Grant, who was the surgical director of our UHN transplant program for a long time, will speak about surgery and life after transplantation. We will follow, so each of these little sessions will be interrupted by questions and answers. So we'll have a short occasion between each of these sections to ask questions, address questions, and we really want this to be as interactive as possible, that it should not be a monologue, but hopefully a dialogue, and we can see also your point of view and what you want to know about this. We will then end the evening with a panel discussion where we try to summarize again and maybe have a little of panel discussion afterwards about open questions, what wasn't answered, was anything not addressed during this evening. Well, thanks again for coming all, and hopefully this will be a good evening and we have a nice talk in between about liver transplantation and how to get the liver transplant.
Thank you, Markus. Good evening, everyone. So my name is Zita Galvin. As Markus said, I'm one of the transplant hepatologists. Many of you I recognize, actually, so it's lovely to see a few familiar faces. I apologize in advance because some of what I'm going to talk about today is just, we'll kind of set the scene for what we talk to patients about when we meet them for the first time in the first assessment clinic. So any of you that I've met in the assessment clinic will have heard much of this before. But we just kind of want to give you an idea of what kind of patients are referred to us, who refers them to us, what are the indications for liver transplant, what kind of liver diseases are sent to us to consider liver transplant for. And then, again, as Markus has already said, Dr. Lilly and Zubeda are then going to go on and talk about what happens once you get listed for transplant and the pathways, including deceased donor and living donor transplant. So just give a little bit of background about our program. The liver transplant program sits within the entire multi-organ transplant program. So here at Toronto General, we don't just transplant livers, but we also transplant hearts, lungs, and kidneys, and pancreases. The liver program itself, it's the largest liver transplant program in Canada. And we have done over 3,000 adult liver transplants since we first started back in 1985. And since we started doing live donor liver transplants, which is in 1990, we've done over 800 living donor transplants, which is a huge number. Obviously, we follow up all of these patients. We do sometimes try to move our post-transplant patients back to their local communities if it's possible. So if there's a local hepatologist who's willing to look after transplant patients, we will try to move them back to the area so it's more convenient for them to follow up there. But even having said that, we still follow up over 2,000 patients post-transplant. Within the program itself, obviously our focus is on providing excellent patient care and excellent patient outcomes. We have a huge multidisciplinary team that is made up of physicians, nurses, advanced nurse practitioners, coordinators, social workers, pathologists, radiologists, everything. So we've got a huge team, some of whom you can see here in the picture. It's probably hard to make some of us out, but I am in there somewhere in the middle of that picture. And we also have a focus on other things. So besides clinical outcomes, we have a huge interest in research and some groundbreaking research that's hopefully going to further improve transplant care into the future. So just to talk then about, who refers patients to us, who do we see, why do we consider liver transplant? And we probably get referred patients, from all over the province. And they generally are referred to us from, hepatologists, gastroenterologists, sometimes physicians within our own network here within the University Health Network. And the first question we ask when we see somebody in an assessment clinic or when we get a referral is, does this person have an indication for liver transplant? In other words, will they be better off with a new liver than the liver that they have right now? And that's the bottom line. And we're providing these liver transplants many times. It's often a life-saving procedure. So we're doing an intervention, a transplant, with the hope that we can improve the quality of a patient's life as well as improve the length of their life. And people get referred to us for many reasons. Often because they have, obviously their liver is sick, and the indication for that can be many reasons. So things like hepatitis B and C we see commonly. Increasingly we're seeing fatty liver disease as an indication for liver transplant. So patients develop cirrhosis because of fat in the liver. Cirrhosis secondary to alcohol use. And then other conditions like primary sclerosing cholangitis, primary biliary cirrhosis, or autoimmune hepatitis. And then there are other rare conditions that can lead to liver cirrhosis. So many of these patients will present to us because their livers are sick. And when your liver is sick, you can present quite yellow. So we call, people can be jaundiced, or they can have ascites, which is a lot of fluid on their abdomens, or they can be quite confused, which we call encephalopathic. And often they're quite sick, tend to have low energy levels, appetite is poor, lose a lot of weight and muscle mass, and generally have a poor quality of life. So in that instance, we see patients and we look up, what are the risks and benefits of transplant? And we recognize that transplant is not without risk. So we want to be sure when we assess a patient in the clinic that the potential benefits of the transplant outweigh the risks that are involved in transplant. Other reasons that people get referred to us, and actually probably the most common reason people get referred to us is for liver cancer, so hepatocellular carcinoma. And a lot of the transplants that we do are for liver cancer. And the reason we do them for cancer is with the hope that we can cure that cancer and get patients better and cancer-free. And then, it's sort of repeating a little of what I've said, but when we put someone through, transplant is not just a straightforward, simple operation. You come in to have your gallbladder or your appendix taken out. It's a big operation. And the reason we do it is with the idea that we're going to improve someone's length of life and or quality of life. And we see that patients after transplant tend to have excellent outcomes. So, it's a real pleasure to work in a post-transplant clinic when you see patients come in who have been really, really sick, and you've gotten to know them quite well in the pre-transplant setting, and they come in after transplant and they have better energy, they've regained weight and muscle mass, their ascites is gone, their encephalopathy is gone, and they have a completely new lease of life. They're out and about doing the things that they did a couple of years before they got sick with their liver disease. And that's the whole reason that we're doing this. That's the idea of liver transplant, is to get people back to a really good quality of life. I should mention just when we list people when we do list people for transplant, when I see them in the clinic and we agree that they have indications for liver transplant, the part of the pathway before you get listed for transplant is to make sure that you're fit enough to actually get through a liver transplant. So everyone that we see in the clinic and we agree that they have indications for transplant goes through an evaluation process. And that involves checking out their heart, their lungs, their kidneys, etc., to make sure that they're fit enough to make it through a liver transplant. And any of you who have been through that will know that. That takes, involves doing some testing. You meet with various members of the team, including the social worker, the surgeons, the anesthetic doctors, etc. Once all of that is done, we would then present everyone's case at a listing meeting. So the team sit down once a week and we discuss all of the patients who have gone through the evaluation for liver transplant. And again, at that point, we discuss the indications for liver transplant and we agree or not whether or not we feel this patient, the benefits of transplant outweigh the risks. We review all the evaluation that has been done and we ensure that there are no contraindications to going ahead with transplant. In other words, nothing that turned up from a cardiac perspective or otherwise that would mean that this person was unlikely to safely get through transplant. And finally, as part of that meeting, we always assess people's social supports and social circumstances to ensure that they have enough, help and support to get them through transplant. Because it's certainly not you need a lot of help and support to get through it. That's probably as much as I'm going to say for the moment. I'm very happy to take any questions if anyone has questions. Dr. Lilly's going to talk a little bit now, I think, about the pathway once you actually get listed, and we'll talk about a little bit about the MELD scoring system, etc., and how we allocate or how we position people on the waiting list. And then Zubaida is going to talk a little bit about the living donor pathway. Yes, please.
You were talking about evaluation prior to being listed.
Yes.
So have you gone through that, and it takes a while, obviously, until you get post-transplantation. How often do you have to repeat that evaluation?
Okay, so I'm going to just repeat the question for the purposes of the video, if that's okay. No, that's perfect. So the question is just with regard to evaluation and how often do we need to repeat tests. So if we've evaluated somebody and listed them for transplant, how often do they need to repeat that testing while they're on the waiting list for transplant? So the answer is it depends on on the kind of testing. So cardiac testing we like to have up to date within a yearly basis. If someone has lung function testing done, they have good lung function and nothing has changed in the interval time, we don't necessarily repeat that. And once you've met anesthesia and social work, provided nothing has changed in the interim, we don't ask people to repeat those either. So it's mainly just the cardiac testing that we keep up to date, unless something happens in the meantime, like someone is hospitalized, unfortunately, for some reason and requires additional investigations. Yeah. Okay, again, I'll just repeat the question. So the question is, in terms of patients on our waiting list who've lost weight or muscle mass, is there a point at which someone has lost too much weight whereby we could no longer consider them a transplant candidate? So I would say the answer to that is it's more of a global picture. So certainly weight and muscle mass plays a role in it. When we list people for transplant, many of our patients who are listed because their livers are sick tend to have lost weight and muscle mass, and usually will continue to do so up until the point when they get a new liver. So we don't necessarily use the weight or muscle mass loss in itself as a contraindication to going ahead, but usually when people are getting globally sicker, there is a point whereby people can get too sick to be transplanted. In other words, we feel that they have become so sick that they are unlikely to have a good outcome after transplant. And patients like that are usually in hospital, sometimes in ICU, have become very frail, very deconditioned, and have become so sick that we feel that the likelihood of a good and successful outcome is less likely.
Thanks and good evening. I'm Les Lilly. I'm the I have the dubious distinction of being one of the senior members of the transplant program. And many of you I've met before, or you've seen me on that rather ancient video that we circulate to our patients when I look much, much younger, because I was much, much younger at the time. And I wanted to add a couple of comments to what Zita just said. I think it's important that before one considers the pathway to a liver transplant, whether it's deceased or living donation, it's important that we have answered that important question as to whether or not this patient is likely to benefit from a transplant. The presence of liver disease only doesn't necessarily mean that someone is going to be better off with a new liver. It's when that liver disease has progressed to the point where that patient's life expectancy is being compromised. And when I see you in the clinic, at some point I almost always apologize for sounding like your insurance agent, because really what we try to do for every patient is to balance the risks versus the benefits. Transplantation itself is not a risk-free procedure. There's the operation itself, there's the post-operative stay, and we are by definition not operating on the healthiest patients in the world. And then there's the lifetime of immunosuppressive medications, which carry their own burden of disease as well. So it's important in every patient that we consider those factors in the balance as well. And I mention this because many patients come to us certainly with liver disease, but the liver disease is not advanced enough that a liver transplant at that point is going to offer a really substantial advantage. And those patients are somewhat disappointed when we defer them. But we're doing that in the long run to ensure that we get the best outcome for that patient, but we also get the best outcome for the graft that we're giving to that patient, and that we ensure that that graft goes to the patient that's going to get the most use out of it. So I think it's important that we emphasize that the assessment phase is critical to determining who we are going to transplant. Of all the patients we see in the assessment clinic, and we see 400 or 500 new referrals per year in our program. It was a huge program. About 60% actually go forward for assessment, and of those, about 60% end up getting listed. So we do, unfortunately, have to say no or not yet to patients almost on a weekly basis as well. in terms of the scope of the program, 3 of the last 5 years, our liver transplant program has been the largest liver transplant program in North America with about 200 transplants per year. And when we compare our outcomes to other large programs in North America, such as San Francisco and Los Angeles and Mayo Clinic and things like that, our results tend to be superior at all points in time post-transplants. We're very proud of the long tradition of excellence that we've built in this program. And we will do our 3,500 liver transplants sometime in the next several weeks, and so we continue to be a very active program. Now, once patients are listed for transplant, they generally just don't get better all of a sudden. The listing is just a way of getting them transplanted. And there are 2 major pathways to receiving a liver transplant in our program. There's deceased donor liver transplantation, which I will focus on. But again, our program is somewhat unique among programs in North America, is that we have a robust and very, very successful living donor liver transplant program as well. And the speakers that follow me will address that. I need to mention that everything that we do in terms of the patients we assess, the patients we list, the patients we transplant is under the overall supervision of the Trillium Gift of Life program. They establish and publish regular guidelines for patient care and patient outcomes, as do all the organ procurement agencies across the country. And they also have determined the system that we use for organ allocation based on precedents set around the world and based on best practice evidence as well. So the timing of referral, the criteria for listing, and the allocation of exception points, which we'll discuss in a little bit, is determined by the Trillium Gift of Life program, and we are constantly being audited for our outcomes in this regard as well. Liver allocation is generally not a complicated business. Organs are allocated on the basis of blood group and roughly on the basis of recipient size. And the Trillium Gift of Life program requires us to offer the next organ that becomes available to the deceased, to the patient on the waiting list in that blood group with the highest sodium MELD score. And that gives me a good opportunity to talk about the sodium MELD score. All of you, or most of you, will have heard about this. I always say that when an organ becomes available, it's not really practical for us to call up all the patients on the waiting list and ask them how they're doing that night. We need a better way of determining which patient on the waiting list needs the organ most that night. Or in other words, which patient on the waiting list that without a transplant is most likely to be dead tomorrow. And the sodium MELD system allows us to do that. By taking a simple set of easily measured liver tests, a value is calculated, and we use that value in several ways. And most of you have heard about this. The higher the MELD score, the sicker the patient. When the sodium MELD score hits 15 or higher, in most cases, those patients' life expectancy will be better with a new liver than with the liver that they have now. The higher the score, the greater the difference in anticipated survival, or as we put it in our terms, the greater the transplant survival benefit. The score includes the bilirubin, the level of jaundice that the patient has, sort of a classic marker of liver disease. It includes the creatinine, which measures kidney function. It includes the INR, which is a measure of blood clotting. The liver makes most of our clotting factors in patients with liver disease have impaired blood clotting, and most of you will tell me all about the bruising that you've had that reflects that. And we use the sodium as a measure of how much salt and water the patients are retaining and how well they're coping with the diuretics that they're taking to manage that as well. So when patients are listed for a liver transplant, irrespective of the diagnosis, irrespective of their gender, irrespective of anything else, their position on the waiting list is determined by this score. And when a deceased organ becomes available tonight, it will be offered to the person in the same blood group with the highest sodium MELD score, with some differentiation in terms of organ size and recipient size matching as well. And that's kind of what it comes down to. Now, as Zita already mentioned, we do a lot of liver transplants here for liver cancer. In fact, each year about 40% of our transplants are done for that reason. Most liver cancer patients have actually fairly well-preserved liver function, and if they were listed for their transplant according to their calculated MELD score, they would never get a transplant because it would be very low. So based on the fact that the presence of liver cancer also affects your survival, patients with cancer are granted extra points using the MELD system, and over waiting time, those points accumulate so that those patients can compete favorably with patients with bad liver disease as well. So it's important that people understand this because according to the guidelines published by Trillium and across the rest of North America, it's the MELD score that's used to allocate organs as well. And this is based, again, on very long strings of published evidence and on best advice, and this is the standard that's used almost everywhere in the world these days. Now, one of the things that I always say to patients is the ideal liver transplant recipient has a bad liver and nothing else wrong with them. And then I always say, I don't know what happened to all those patients. I guess we got them all transplanted, because most of the patients we see today are not only sicker than they were 10 or 20 years ago, but they're also more likely to have other medical problems. And it's increasingly important that these patients do everything within their own power to maintain their state of fitness as they're waiting. Or to use another one of my favorite expressions, the way that people look when they come out of the OR from their transplant depends mostly on how they looked when they went into the OR. If somebody is at home, exercising regularly, eating properly, and gets called in for their transplant, they're much more likely to have a complication-free, short stay, to be out of bed the day after surgery and to be home in 10 days than somebody that we transplant from the intensive care unit. It's just common sense. And of course, given that liver disease results in the loss of muscle mass, it is challenging for our patients to maintain their muscle mass, but we ask them to do so in spite of the way they feel. We ask them to use a lot of supplementation to maintain their protein intake, to try to keep that muscle mass loss to a minimum. We ask them to try to take regular exercise, to judge for themselves if there's a couple of hours every day when they feel reasonably good, to take advantage of that, because most of the time for liver patients, their main problem is ongoing lack of energy. So it's very difficult to get patients to do this, but it's highly important that they do so in order to minimize the risks of surgery and to maximize the benefits as well. Similarly, when our patients are on the transplant waiting list and they become unwell, we need to know that, because it may affect their status on the list. It may make them temporarily ineligible for a transplant, or on the other hand, it might make their need for transplant greater. And it's particularly important that patients are aware of the incipient complications of their liver disease so that we can be informed of that. Patients on the waiting list are asked to do blood tests on a regular basis, typically monthly, because those blood tests are what actually determines whether they're on the waiting list and what their position on the waiting list is. So as much as you guys complain about all the blood tests that we do, these are important, because without them we can't rank you on the waiting list and give you the position on the waiting list that you deserve. One of our constant challenges is that we serve patients from all over Ontario. We serve about 11 million Ontarians in our transplant program. And there are hundreds of hospitals in Ontario, and any given day our patients are being admitted somewhere for something, and it's important that we hear about that. And I always tell the patients, I know that it would be great if the doctor looking after you picked up the phone 5 minutes later and called me. We can't rely on them doing that, so we do ask you to try to get in touch with us also through the transplant office to let us know if your husband or wife or son or daughter or sister or brother has been hospitalized. It's important because, again, it can affect someone's status on the waiting list, and we might even be able to provide some useful advice to the people looking after the patient in terms of getting them through their complication as well. So I think it's that degree of communication is particularly important. So that's the points there. Come to your appointments so that we can continually reassess your status. Get your blood tests done regularly so that we can keep your sodium MELD score where it belongs. And please, if anything major happens, let us know or arrange for someone to let us know so that we can chase things down and we can make the appropriate modifications to someone's status on the waiting list. So those are my slides. I spent all afternoon running a transplant clinic. I still feel I'm running a transplant clinic here because this is exactly what I say in the clinic as well. I have time for questions. Any hands? Yes. The question is regarding protein supplementation. It's a good question because for many years, when patients with liver disease develop problems with memory and concentration and confusion, the classic treatment was actually to protein restrict patients because ammonia, which is what we blame for all of our patients' muddled thinking, is a byproduct of protein breakdown. It turns out that we were not doing our patients any favors because we were actually worsening their malnutrition by protein restricting them. So what we talk about these days is rather than protein restriction, we talk about protein supplementation, but the real key word is protein modification. It's important in order to maintain muscle mass that your body has enough substrate to work with. So we generally recommend that our patients ensure that their diet contains about 1.5 grams of protein per kilogram of their body weight. So if they weigh 70 kilograms, they need 100 grams of protein. It's not a good idea for them to sit down and eat a steak every night. First of all, who can afford it? But also the body will handle protein coming from non-red meat sources a little bit better. And so vegetable sources, non-red meat sources such as chicken or pork and things like that. And even with that, it's difficult for many patients because their appetites are terrible and they feel full so quickly. And we do encourage our patients to stock the fridge with a wide variety of different colored supplements, you know, the white ones, the orange ones, the brown ones, Ensure and Boost and things like that, with at least the goal of trying to approach that target of 1.5 grams of protein per kilogram body weight. And even patients who come to us with fatty liver disease who are obese, many of those patients are at the same time malnourished because their protein may be down and the weight is sort of concealing that because they're actually overweight at the time as well. So protein supplementation is key to maintaining our patients' muscle mass so that they can remain active, so that they can come in for their transplant and get that great outcome that we're so proud of. Long answer to a short question, but that's me. Yes?
In terms of the exceptional points for cancer patients, so I'm talking obviously of self-registered type of cancer patient, very healthy at this point. The type of liver patient you sit there, you don't know where they went.
Yeah, well, they still exist, but they've all got cancer. There you go. So, yeah.
So in about 4 months, I'll have 30 points.
Well, let me tell you what that means.
What does that mean in
Yeah.
terms of competing?
Well, again, because deceased donors are scarce, the patients actually have to get reasonably sick, as defined by their MELD score, before they get to the top of the waiting list and attract a deceased donor offer. Patients with liver cancer who fall within guidelines described by the Trillium Gift of Life program are assigned 22 exception points. Every 3 months, they gain 3 more exception points. And in order for offers to start coming in, typically they have to have between 28 and 31 exception points. So for the most part, tumor patients can expect to wait about a year with those exception points before offers start coming in. Now, that's a rough estimate because I have no control over the number of organs that come in. I have no control over what blood group they all belong to. And the waiting list, I always say, is a little bit like the staircases at Hogwarts. Every time I come into work, it changes itself around. New patients are added, patients are transplanted, patients are taken away. But as a general rule of thumb, with exception points, whether it's for cancer or other indications, it takes patients about a year to accumulate enough points in order for them to be in a position to attract an offer. The problem is that I don't think that cancer reads the manual because cancer does what cancer does, and a year is a long time to wait for an operation if you've got cancer. Now, we don't just let our patients sit there and wait. We're very aggressive in terms of offering what we call bridging therapy, a radiofrequency ablation where we zap the tumors, chemoembolization where we infuse chemotherapeutic agents, external beam radiation. We offer all of those things. But when our cancer patients are added to the waiting list, we tell them that if the cancer grows beyond a certain point or grows into the large blood vessels or spreads beyond the liver, then transplant is no longer going to be offered because it's not going to cure you at that point. I'm sure if there are other questions, we'll cover them at the end. I think, Zubeda, you're up to bat next. I'm sorry, was there another question? Oh, sorry, yeah.
I know he's telling you this is why you can't proceed. Is there, I noticed that there wasn't a thing as far as age goes.
The question is age, and I would have to say that age is something that we would classify as a relative contraindication to transplant. Our program does regularly list patients for transplant who are 70 or 71 or 72 years of age. Those patients have to be really essentially free of other health issues, and with the anticipation that they'll not only get through surgery successfully, but will go on to enjoy the 5-year survival that we anticipate all of our patients will get. The problem is that with age in many patients comes lots of other unwelcome passengers, such as diabetes and hypertension and coronary artery disease and things like that as well. So the older the patients get, the more challenging it is for us to actually get that patient through an evaluation and onto the transplant list. And again, the challenge that we face with a limited organ supply is that we want to ensure that each patient gets the best possible outcome. And we recognize that if we transplant someone and they have a poor outcome, irrespective of their age, for example, that not only is that bad for that patient, but it may also be bad for the patient that otherwise might have received that liver and had a better outcome. And frankly, when you talk about living donation, which we're going to, of course, as well, the argument is similar because you're not going to put a healthy individual through an operation that carries a risk to them unless you're reasonably certain you're going to get a terrific outcome in the recipient. So whether it's the use of a limited resource from a deceased donor pool or the use of a scarce resource from a living person, we have a responsibility to each patient, but to all the patients, to get the best possible results from transplantation. It doesn't make sense to put somebody through an operation either way if we're not anticipating a good outcome.
Okay, so in a nutshell, that means at the age of 65, we don't take your application?
No, we're talking about recipients right now. I'm not talking about donors. No, I mean, we have, we've transplanted recipients, I think 72 point something years of age is our oldest recipient. It's more challenging to get an older patient through their evaluation process and on the waiting list, as I said, because they're more likely to have other health issues. But we would not refuse to assess a 65-year-old because he was 65, or even a 70-year-old. Yeah. It's got to do with what Dr. Galvin said earlier on. It's got to do with a global assessment, you know. We always like to see patients who fool us by looking much younger than they actually are. People said that about me at one point. Not anymore. The gray hair is giving me away. But what we care about is physiological age, is functional age, more than chronological age. Nevertheless, it's clear that a 72-year-old doesn't have the same bounce in his bungee as a 52-year-old if they have a complication. So we have to, again, balance those. That's a reference to Wallace and Gromit. I don't know if you know it or not, but that's the balancing that we have to do. Okay.
Thank you, Dr. Lilly. Thank you, everyone, for taking the time to be here today. My name is Zubaida. I'm the Living Liver Donor Coordinator. And I wanted to take some time just to shed some light on one of the pathways for liver transplantation, which is living organ donation. So we know that it is a shorter pathway to liver transplantation. As you've been hearing, just to summarize, so liver transplant is a life-saving treatment. Really in our ideal world, in our ideal world, everyone who needs a liver transplant would receive one. But as we know, the supply doesn't meet the demand, and for that reason, we offer living donation here in our program. And I want to take a moment to acknowledge that really this is only made possible by the generosity of living donors to provide this life-saving gift for recipients. So you've been hearing in terms of the benefits of living donation for the recipients, that it's life-saving. It is a shorter time, and as we know, the longer the wait is, do miss their opportunity for a transplant because that window closes because of other complications. Also, living donation does allow a faster return to health, mainly because of that reason as well. But really, I also want to take a moment to just acknowledge as well or benefits that living donors get from this. So we know that this doesn't directly medically benefit living donors. We know that the surgery doesn't directly medically benefit donors. In fact, it does come with potential risks and complications for them, and so for that reason, we do have to assess them carefully for suitability for that. But really, what donors get out of this is the satisfaction of having helped someone, having given back, and also the ability and the opportunity to spend more time with that loved one or family member or friend that they've directed that donation to. And I know from a recipient perspective as well that some parents often struggle with accepting donations from children, and it can be a difficult conversation to have, but also, you know, out of concern of having them to go through the major surgery to provide this gift. And really from the donor perspective, we make sure that they understand that process, but also the benefit for them is that they have that family member or loved one around. So donor safety is what underpins our assessments, and really what we want is to make sure that this is safe for the donor from all aspects, medically, surgically, and also preserving their psychological and mental well-being as well. In terms of the criteria for living donors, they do have to be between ages 16 to 60. They have to be in excellent health as well, and with a normal functioning liver. And really, we also look for support from family members and their employer as well to be able to go through this major surgery and recover as well after. And again, it does have to be voluntary, so we do take our time to assess that and also make sure that every step of the assessment is explained to the donor so they understand every step of the way. In terms of, that's a story that you can go to on the website. It's a living donor and recipient pair. They actually have shared their story online. But just to give you a kind of a background or picture of our donors, living donors and their recipients. So 2/3 of our living donors are related. About just under 50%, so about 45% are friends, and 1 in 5 are spouses. We have about 11% or so anonymous donors that come forward that do not have a direct relationship with their recipient. And really I want to highlight here is that this is just to give you a general picture of who the donor profile, what the donor profile looks like. There is no one relationship or any that makes you more suitable to be a donor. Just because there's more women donating doesn't mean that more women are likely to be more suitable. Really, we look at the age and all the other criteria and medical and psychosocial suitability as well. So this is just kind of FYI. And then going back to that point of donor safety, really. So UHN does have strict guidelines, ethical guidelines as well that we follow in terms of assessing our living donors. And really we do this also mainly by having separate teams for the donor, a primary team for the donor that doesn't look after the recipient so that there aren't any conflicts, and that process is separate, and confidentiality is maintained as well. Some of the kind of practical things to keep in mind. So with donor assessments, we only assess one donor at a time. Generally, the workup can take anywhere between 4 to 6 weeks. And on average, from the time of application to time of surgery, it would be an average of 8 weeks in general. Now, of course, recipient status as well is kept in mind. OHIP does cover the cost of surgery and the hospital admission, so that's covered by the either OHIP or the recipient's health insurance plan covers the donor surgery. And then there are reimbursement programs available for any of the out-of-pocket expenses that come with attending assessment appointments and being closer to the hospital for the period of surgery. Not everything is covered, but there are programs that cover up to $5,000 for some of those expenses. And then in terms of out-of-province recipients and out-of-province donors, so like I mentioned, just going back to the point, the cost of the surgery and the hospital admission is billed to the recipient's health insurance plan. So even if it is an out-of-province donor, then that we would accept that as well. How do you become a living donor? So once we tell donors that once they've read all the information and have had their main questions answered about the process, they can do this through reading the manual, which is available on our website. So it's www.uhn.ca/transplant. And there they'll find about a 30-page document. I know it's very long, but it details the entire process from the assessment all the way until the follow-up required. And so once donors have had a chance to read that, they would have to complete the application form on our website. It's an 11-page document. It just goes over health history questions, and then they would just have to attach a copy of their blood type and submit that to our office by mail, email, fax, whatever way is convenient. And someone from our office will contact them to confirm that we've received the application, so definitely do look out for that. And once we've received it, we will begin the review and go from there. And just to point out as well, there will be some living donor champion classes that will be offered, and I think Paula will keep you updated in terms of just to help recipients kind of broach the conversation about telling others about living donation and just explaining that to your circle. Thank you. I'll take a moment to just see if there's any questions in the room related to the process or the assessment. Yeah.
Yeah, just quickly on the coverage for out-of-country donors. Mm-hmm. Is the surgery covered?
It would be for a recipient who's listed in our program? Yes. Yeah. Yeah. So just to... So just to recap the question, so the question is for out-of-country donors who are directing to recipients who are listed in our program here. So like I said, the donor's surgery and hospital stay will be covered under the recipient's health insurance plan. And in terms of the medications, the cost of the medications after the surgery are not covered. Those would be out of, the donor would have to pay for them out of pocket. And again, if it is an Ontario resident, if the recipient is an Ontario resident, they will be able to qualify for PRELOD, which is the reimbursement program. Keep in mind that international donor assessments do take some time. They take a longer process than local donors, because we do have to assess them and arrange for local screening tests before they're able to travel here to our center.
Good evening. Maybe just for my own information, if I could ask you just to raise hands. I'm curious as to who's here tonight. Maybe if you don't mind, those of you who are on our waiting list, if you could raise your hands. Okay, and then we have accompanying, I guess, partners or family, friends, support people. And who, are there others here? I didn't see everyone raise their hands. I'm curious. Just any insights, just so we understand who's joining us.
So I'm Jessica. I'm a PSC patient. So I have a MELD score of maybe 15, but I'm not near needing a transplant. I'm not sick enough,
Okay.
so to speak.
Great.
But it is a progressive, non-curable disease, so I mean, the expectation is that eventually it's going to get worse, and eventually I will need one. So this is just more for learning more information. It's also unpredictable as well, so at any moment, who knows? Tomorrow I might need a transplant. I've been in a situation like that before, so.
Good.
Some advanced planning, information gathering. Good. As you heard earlier, my name's David Grant. I'm one of the transplant surgeons. I'm also a donor surgeon, so I work on both sides of that divide. And I've got about 4 slides, and what I'd like to do is just walk you through particularly what is involved with the different kinds of surgery that we perform. The first slide just shows that the case mix of the type of transplants that we perform. And I put that up just to show that our program is unique in some aspects. So in the United States, about 96% of the transplants are deceased donor transplants. In Toronto, about 30% of our adult transplants are from live donors. And in children, that figure is closer to 80% of our children have live donors. Now, we feel pretty good about that because it's a lot different than the rest of the Western world, but I would put it in perspective and say that in the Eastern world, in Asia, India, other parts of the world, live donation, in fact, is the standard of care, partly because deceased donation is often not available, but also in many of these countries, they perceive live donation to be the best path forward. So this gives you some context for our presentation. So Zubaida has explained about the donor workup, and I would just like to re-emphasize the primary consideration there is donor safety. That's our first and foremost consideration. We never take extra risks or unnecessary risks. And I'm sure any of the recipients here who have someone they care about, family, friends, neighbors that are being evaluated, you wouldn't want us to take risks to help you. So that's our first priority. So the donors have to be completely healthy. And they have to understand what's involved, and there are some risks involved. So the surgery takes about 7 hours. Donors are in hospital from 5 to 7 days. Most people are back to desk jobs by about 6 weeks. If you're doing really heavy physical labor kind of work, you might be off work for up to 3 months, mostly just to get back into good shape to do heavy physical work like that. But we also have high school students who have been back to high school 2 or 3 weeks after their surgery. So a lot of the return to work, return to activities is obviously affected by your fitness going into this and your motivation. When we're donating to a child, we remove about 20% of the liver. When we're donating to an adult, we're usually removing somewhere between 65 to 70% of the liver. And the really cool thing about the liver is it grows back. So even though we take out a big chunk of the liver and temporarily they have some liver dysfunction, even by 2 weeks their function returns to normal. And because the liver grows back, we expect that patients who undergo this surgery and recover will carry on and live a completely normal life afterwards. So that's one of the amazing things about this surgery. So although it's big surgery and recovery is involved, in the long term we expect that they'll get back to a completely normal life. These are the 2 different types of surgery, and I'm not going to go into the details, but other than just to say this is for us, I mean, it's kind of like the mechanic fixing the bad carburetor. We swap out the bad part, put in the new part back where the old part was, and if the rest of the body or the car is in good shape, then you carry on pretty normally afterwards. So with the liver transplant, we have to make about 5 different surgical connections. So the first part of the operation is just removing the old liver, and then there's about 5 different connections that have to be made. And it's very similar whether it's a whole liver or part of a liver. The operation takes 7 or 8 hours. And the recovery afterwards is very similar. Most adults are in hospital just about a week afterwards if all goes well, and if they walk into the hospital. And finally, just to emphasize, the whole point of this is to help you have a successful transplant and get back to a healthy, active life. And it's a real privilege to have a job like mine where we can see someone who's so sick going into the operation and help them get back to a completely normal life. There is monitoring required. It's more intensive immediately after the surgery. For the first few weeks, you have to blood checked pretty regularly and come back and forth to the clinic. But several years after the transplant, you may only need to be checked in the clinic once a year. So once you've recovered, we expect that you'll get back to a very healthy, active life. And I'm the oldest person on the liver transplant surgery staff, and I'm proud to say that some of the patients that I transplanted as a resident are now more than 40 years after transplantation, doing all sorts of cool things.